for the outpatient total joints. Thank you, David, for joining us.
Thanks so much for having me. Again, I'm Dave Kuppersmith. I'm internal medicine. I work here at the Stedman Clinic in Vail, titled Pre-Operative Medical Evaluation of Outpatient Total Joints. I have no disclosures relevant to this talk. So if we think about what goes into a successful total joint, I think now more than ever, given the COVID pandemic, it really stresses the importance of getting people out of the hospital and moving towards outpatient procedures. And my job here is to make sure these patients are going to fly, because you can have a completely perfect surgery, but if the patients are not medically optimized, they're going to crash. And so what we do here is from the time the patients are booked for surgery, at that point, we establish a relationship with the patient. I oftentimes will go into the room and just start talking to the patients, figure out what medications they might be on, see if there's any specialists that they need to see before. And we might be 3-4 months out from surgery. But it helps to appease a lot of the anxiety that the patients may have. And so, we're really focused on identifying potential risk factors. That's how we optimize the patients. Anything that we can do to act on before is going to have a tremendous benefit in getting them out the same day. For instance, oftentimes we see patients urinating 4 or 5 times a night. Well, those patients are at tremendously increased risk for post-op urinary retention, especially after spinal anesthesia. Respiratory status with sleep apnea and obesity, hypoventilation syndrome. Is there anything that we can do prior to surgery to help get them better? And so what do? Everyone comes here about 2 weeks before their surgery. And at that point, we order all relevant testing. We go through the patient history, family history. We manage all their medications, and we get all the appropriate testing that needs to be done. Because based on all the history and the testing, we're trying to figure out what we can do to help these patients fly through surgery. For instance, are they hyponatremic, and are they at increased risk for SIADH and post-op readmissions because their sodium's dropping? Are they at increased risk for syncope? So we're just trying to identify all these risk factors that we can potentially act on. You cannot take a cookie cutter approach to DVT prophylaxis. You put everyone on aspirin, you're going to have people clotting, and you put everyone on Eliquis or Xarelto, and you're going to have a lot of people bleeding into the joint, creating arthrofibrosis and a stiff joint. One thing, when I was an intern at Cornell, I would round on all the prosthetic joint infections. I'd look in everyone's mouth, and I started to notice that everyone who had a prosthetic joint infection had a horrible oral dentition. And so this is something that we can do, prior to surgery. An ounce of prevention is worth a pound of cure. We pull the tooth before, we're at significantly less risk of infection postoperatively. And so what are we creating in talking to the patients? Well, we're creating a very clear, concise document. It's a smooth handoff between, from the clinic to the nurses, to the anesthesiologists, to the surgeons, to the PACU nurses. And so everyone knows exactly what's going on. And it ensures that everyone's taking care of the patient appropriately. So this is an example of a document that we pretty much do for every single patient. As you can see, it's got all the medications, everything's outlined, has all the pertinent information that's super easy to access. But most importantly, every single problem's been identified before surgery. It's been addressed, and it's been optimized. And so this is just an example of a pre-op clearance that's come through our clinic. It's clearing the patient for surgery. From a medical legal standpoint, it does absolutely nothing to help take care of the patient the day of the surgery. This is an example of an EKG that was faxed on a Friday night before a Monday morning surgery. Well, the patient gets to the pre-op holding area. He's got a left bundle branch block, and we can't do anything about it. So we're creating an interdisciplinary approach of active communication between the internist, the orthopedic surgeon, the anesthesiologist, and And what it really does is it optimizes the patient. It gets them all ready to fly through. Everything's been taken care of, minimizes complications, but also allows the anesthesiologist the morning of to go from patient to patient knowing that everything's been taken care of. And so it's really just creating a smooth throughput from the time they check in until the time that they're discharged. Everything has really been addressed. And so if you think about what goes into a successful outpatient total joint from a medicine standpoint, we're risk stratifying who's appropriate. We're doing everything on the front end so that everything's smooth on the back end. We're managing the patient expectations, and we're participating in shared decision-making with the patients. We've already established a relationship with them preoperatively. We can help them the day of surgery, and we can help them after surgery too. And most importantly, it's communication amongst all the disciplines, from the patient to the anesthesiologist, to the surgeon, to the internist, to the nurses. All of this ensuring a perfect outcome for the patient. And I mean this. If anyone has any questions, anything at all, I'm happy to help. Please call. Don't hesitate to call or email. Thank you.